Now let's begin with the next segment of pathology, and that is hemat. Now you know hematology comprises of three main chapters: red blood cells, white blood cells and platelets. But the same hematology is also going to cover up a great chunk of your medicine, guys, because the same concepts and topics and diseases are going to come up there as well. So might as well finish it off well in both the places, but primarily start with your pathology so that a lot of your medicine gets covered already over here. Let's start. When I talk about hemat, the first thing that I have to talk about is where is hematopoiesis occurring. So let's start from intrauterine life. So please remember, for the first 1 to 3 months of our life, this process of making of blood cells occurs in the yolk sac, because you know who starts taking up by 3 months? By 3 months, it's the liver who starts taking up this entire thing. This entire process is started off by the liver, and you know the liver is going to continue. But by the 4th month, also something that starts off is the bones. The bone marrow of which bones? The bone marrow of all the bones of the body. And this process is going to occur till birth and even till puberty. All the bones are able to make. But after puberty, it is seen that it is only and only the long bones of the body that can make sufficient amount of bone marrow. So remember, long bones. Ultimately, if you ask in an adult who is making all of the blood supply, it's the long bone marrows which is doing that, repeating. So the first 3 months is by the yolk sac. Then gradually the liver takes up the responsibility. Liver also continues till a great time, but meanwhile by the 4th month even the bone marrow starts sharing the responsibility. But ultimately in an adult who is doing this work, it is a long bone which is doing this. So now, having discussed that, we need to start off with all our bone marrow basics. That means we need to first understand what is a bone marrow aspirate, biopsy, what are the stains, what is peripheral smear, these basic tiny little things we usually falter on. So let's get going. So if I ask you what are the two main techniques that you have something known as a bone marrow aspirate and a bone marrow biopsy. So simple, what is a BMA? BMA is a bone marrow aspirate. You know what is an aspirate? Aspirate is the way you take a blood sample. How do we take a blood sample? From the cubital fossa, we take a blood sample, we put a syringe, we take blood out. The only difference is you're going to take the same syringe and the same needle. I'll tell you the needle is the same syringe you take, but you are going to pull the blood marrow or the bone marrow out. It's just like a blood sample, but this time you're doing it from the bone. Whereas, what is BMB? BMB stands for bone marrow biopsy. Biopsy means it's a tissue. You're not going to take any liquidy material. You're going to take proper tissue. So remember, be it a bone marrow aspirate or a bone marrow biopsy, where are you going to do it from? You are going to the most common or the preferred site is the posterior superior iliac spine. The PSIS is the most common location from which this is done, be it BMA and BMB, because this gives you not only a cellular marrow, it gives you a cellular marrow, and it's also easier. It's more easy to perform. And I'll tell you why. Because when would it not be easy to perform? Because posterior superior iliac spine means that what if the person is obese? Now, if a person is obese, there will be a very thick pad of fat on top of it. Then it will be difficult to make my needle reach the bone. In those cases, in obese individuals, what will I select? I will select anterior superior iliac spine, because that is more towards the surface, right? And even if it's a person is obese, I'll be able to palpate that more easily. So for all practical purposes, I take up PSIS. It's easier, but where is it not so easy? It's not so easy in case of obese individuals, and for them I'm going to take up ASIS. What about children? In children, I usually tend to do it from the anteromedial surface of the tibia. From the anteromedial surface of the tibia is where I prefer to do the bone marrow studies in a child. Earlier, they also used to say that sternum is also a good source. I agree, sternum is good. But then, problem with sternum is that it's in proximity to some really vital, important organs in the thorax. Needle going here and there, and it can be so grave, so dangerous, so not, something that will give me also a scare while doing. So sternum is one of the last things that I will look out for. Primarily, I will go in for PSIS. If it's an obese individual, I go in for anterior superior iliac spine, and if it's a child, we try to go for the tibia. These are the findings that you have to know for a bone marrow aspirate and a bone marrow biopsy. So the next thing that you'll ask me is, how are you going to do that, and what exactly is going to be the procedure going to be? So first and foremost, have a look at these. These are the needles going to be used for a bone marrow aspirate. We have two needles called salhas and klimas. There are other needles also like Islam and so on, but mostly you get questions on salhas and klima needle. And this is a recent question that came in the exam INI-CET as well. So remember, when you talk about the salhas needle, how will I identify which out of these is salhas or klima? You will look at the screw. In one of the needles, the screw, the one to tighten, is on the side, and in one of the needles, the screw is going to be longitudinal like this. So when you get to see a side screw, that is a salhas needle. Whereas when you get to see a longitudinal screw, that is going to be a klima needle. So S for S is going to be simple, na? Side screw wala is going to be the salhas needle, and longitudinal one is going to be the klima needle. How easy to identify. Side screw is salhas needle, S for S, and longitudinal one is going to be the klima needle. Yes, that is what? For bone marrow aspirate. What do we, and once you've done a bone marrow aspirate, how is it going to look like? So I've got you a tray over here. Can you all see what all does this tray have? So this tray is going to have some tiny little needles. It will have some local anesthetic because local anesthesia is needed for the overlying skin. It has a syringe. It has multiple syringes. It has some containers. It has some slides over here. It has that purple vacutainer because maybe I want to collect some sample in the purple vacutainer also. But ultimately, I have to put all of that material onto a slide. Over here, right? How does a bone marrow aspirate slide look like? Have a look at this. See guys, this is, you'll say that ma'am, this is looking like any other peripheral smear that, you know, we used to study in the exam that a peripheral smear is going to look like a tongue-shaped smear. This is looking like a peripheral smear. How can you look at it and so confidently say that this is a bone marrow aspirate? This is not a peripheral smear, because I also see that this has some additional ... over here. What is this ... This is not just blood. If it would have been just blood, I would have seen a film like that. But this also has blood along with some ... means bone marrow particles. This also tends to show you bone marrow particles. So please remember, blood along with bone marrow particles is what you're going to see in a bone marrow aspirate. This is how an aspirate slide looks like. This is all about a bone marrow aspirate. Now what are we going to move on to next? A bone marrow biopsy. What is the needle that you use there? It's a Jamshidi needle. So this is the image that we have for a bone marrow biopsy. What is the bone marrow biopsy needle known as? It's the very, very famous Jamshidi needle. It's the very, very famous Jamshidi, or also known as the trephine biopsy needle. The trephine biopsy needle, and you have two versions of it. Firstly, how I identify it. It is identified as a T-shaped needle. That's how you can see it's a T shape over here and it's a T shape over here. But I've got two versions because what we used to use in earlier days were reusable ones, the stainless steel reusable ones. Now you know that's no longer a procedure. We don't use the reusable ones. We have one-time usage needles. So now a proper plastic handle and a needle has come. But either way, I think the overall configuration remains the same, right? You have a T-shaped needle which you have over here. That is the bone marrow biopsy or the Jamshidi trephine biopsy needle. So you're done with two things. Now you've done bone marrow aspirate. What all needles did you use for a bone marrow aspirate? You used the very, very famous, the salhas and the klima needle. Here you've done bone marrow biopsy. You have used the Jamshidi trephine biopsy needle. Now once you've got the biopsy with you, what are the processes that you're going to do? You've got a tissue. You've got an entire tissue, like 1.5 centimeter of the tissue sample that you've got, and biopsy, full bone piece. What are you going to do? First step is that you're going to fix the tissue. Be it anything in pathology, how do you fix it? You fix it in 10% neutral buffered formalin. 10% NBF is the fixative for everything in light microscopy. So you fix it, but can you directly put it into your machine? Don't you feel you've got a piece of bone? If you put it directly in your machine, some parts of your machine only while cutting it might break off. So first, kind of soften the bone. How do I soften the bone? I will have to remove the calcium. So the second one is going to be decalcify. decalcification. When I'm talking about decalcification, please note that decalcification is done most commonly by using a very famous thing called 10 to 15% of EDTA. Till now, you have always heard what is EDTA? EDTA is an anticoagulant. EDTA is something you add to blood so that it doesn't clot. Why do you add EDTA to blood? Because EDTA has a property, it will take away all the calcium. If calcium is not there, blood will not clot. Same problem over here. I want calcium to come out. So when I wanted decalcification to occur, I used EDTA. So in other words, EDTA is a calcium chelator. It is going to take out the calcium, and that is what I wanted. My bone has become very soft. I can use other acids also. I can use formic acid, I can use nitric acid, but those acids are very, very strong. If I use those, all my cells will also die off. RBC, WBC, platelet, they will also die off. I don't want them to die. I only want the calcium to come out. So that is why I put it in 10 to 15% EDTA. It takes 5 days or so. And then I put it in my machine, and then I'm ready for the same thing. What do you do with every histopath sample? You do paraffin embedding, and finally you cut the sections. And if it is a biopsy, what is the most important stain? Coming back to the pink and blue of pathology, the blue color stain is hematoxylin, the pink color stain is eosin. So here you go. This is how your biopsy is going to look like. This is the normal bone marrow biopsy sample, and you can see the pink and blue, that is the HNE stain, has been used. Let's label the parts of it. Bone, marrow. So look at the bone and then look at the marrow. When I talk about bone, I can see these pink lines going everywhere, and these pink lines are referred to as the bony trabeculae. So this is the bony part of it. The bony part I have understood. This is the bony trabeculae. Now after the bone, I have to focus on the marrow. So what is the marrow going to have? The marrow has two aspects. Very, very important. Bone marrow, number one, has cells, and number two has fat. And you know, by looking at the cells and the fat, I can ideally or kind of guess the age also of the patient. I'll tell you how. So all these white spaces, that you're seeing, this is all the fatty part. So all these white spaces are fat. Whereas what are the cells in between? The cells that you're getting in between, all these blue color dot, these are all the cells that we have. So what are the two parts of a bone marrow? Bone and marrow has two parts, cells and fat. So remember that when I'm talking about a child, what do you think a child is going to have? Child is going to have too much of ability to make cells. So child is going to have 75% cells and only 25% fat, because child more ability to produce cells, right? So more of cells. Whereas if I'm talking about a very, very old person, an elderly person, the ability to make cells goes very, very low. Your ability to make new things is very low. So your cells are only going to be 25%, and majority of your bone marrow will become fatty. So simple, it's a 75-25, but children have more of cells because they can make more things, so they have more of cells, and elderly people have more of fat because they cannot make too many cells. But what about the question that came in the paper? They just asked you not a child, not extremes, no chota bacha, no big person. They just asked you somewhere in between as an adult. And remember, an adult has 50%, means they asked you what is the ratio of cells is to fat in an adult. You said 1:1. In simple words, you said 1:1. You have equal amount of fat and you have equal amount of cells. This is a very general thing, because adult is anyone starting from 18 up till even 50, 60 and beyond. In other words, we say that I can guess the cellularity. What should the ideal cellularity be? The ideal cellularity is equal to 100 minus age. So let me say, for example, you have a 10-year-old boy. Okay, you have a 10-year-old boy. So what is the expected cellularity in him? You will say 100 minus 10 years. Matlab expected cellularity should be 90%, which is right. A 10-year-old boy will have lots of cells. He has 90% cells. Whereas if I have, for example, an 80-year-old person, a very, very old person, 80-year-old person, what is his cellularity going to be? Very, very less. As you get old, your ability to make cells goes very down. So greater the age, less are going to be the cells. So I have a simple way of analyzing it. Cellularity is defined as 100 minus age. This is a simple rule that pathologists use in the lab. So bone marrow biopsy assessment is done. Let me ask you this first question now. Let me see how much have you learned. Can you analyze what are these pink strands that you're seeing? These must be the bony trabeculae, the bony part. And after that, what are the other things that you notice? In the center, you have something called fat, right? So I realized that majority of it is all fat only. Majority of what I'm seeing everywhere is fat, and I hardly see any amount of cells. Very few clusters of cells are noted over here. Firstly, if I ask you that this patient has no disease at all, what do you think is the age of this patient? You will say hardly 10% cells are there. Hardly any cells are there. Mainly it is fat. This must be somewhere around a 90-year-old, 85, 90-year-old person. This looks like differential diagnosis. Batao. Number one, you say that this is an elderly person, somewhere in his 85 or 90-year-old kind of a person, because cells are very, very less. But I give you a twist in the plot and I say, no, listen, this is a 20-year-old person. And you'll be very shocked. How can this be a 20-year-old person? Look at the cells are so less and the fat is so much. Why is this a 20? So this means this person is having a problem. What problem is he having? This could be a case of aplastic anemia. So what if, example, if this is a 22-year-old boy, if it's a 22-year-old man, I don't expect 22-year-old to have so much of fat. If he's having so much of fat and so little chota sa cell amount, means his bone marrow is not doing any work. This is a case of aplastic anemia. So that is how we'll be assessing bone marrows. I hope you're gathering some confidence out of it. Now, many students ask me, do you do both? Do you always do a bone marrow aspirate and a bone marrow biopsy? Yes, we always do both, bone marrow aspirate and a bone marrow biopsy. And on both, I have different set of diseases that I'll diagnose. But one thing that you have to notice, that sometimes a bone marrow aspirate gives no material. Imagine you have a bone marrow. I'll draw one bone marrow for you. You have a bone marrow. You put your needle into it. Okay, and you're trying to take with a syringe, aspirate, na? Aspirate matlab with a syringe. You're trying to take out some material with a syringe, but you realize that I'm unable to take out any material. My syringe is only having air. It is not having any material. Why? Firstly, that situation is known as a dry tap. When there is no material, that situation is known as a dry tap. Dry, all the syringe is empty, air, there is no blood, no material coming out. Why? Because probably there was nothing in the bone marrow. It was a case of aplastic anemia. When the bone marrow is not doing any or making any cells, how will you get anything in your syringe? It's a case of aplastic anemia. Or the bone marrow is doing its work, but it's got a lot of fibrosis. There's a lot of fibrosis. So maybe it's a case of myelofibrosis. Now, myelofibrosis means a mesh. Will your needle be able to go through and will you be able to take material out? No. Your cells are stuck in this mesh. So myelofibrosis will result in dry tap. As you will read gradually the WBC chapter, hairy cell leukemia also shows you fibrosis. AML M7 also shows you fibrosis. So my underlying concept is that whenever there will be a fibrosis in the marrow, there is not going to be any kind of ability to take cells out of it. That is what is important. Coming to the last part. The last part is myelophthisic anemia, which you might not know right now. Myelophthisic anemia is nothing but this is a kind of an anemia when there is something invading the marrow. So for example, if there is metastasis to the marrow, some other thing has gone to the marrow or TB has gone to the marrow. So granulomas are there or some cancer cells are there. So the other cells will not be there. That is why I'm not seeing anything on a bone marrow aspirate. I'm getting a dry tap. So repeating once again, whether the cell is not being produced like aplastic anemia, myelophthisic anemia, or if I'm having a lot of myelofibrosis like myelofibrosis, hairy cell leukemia, AML M7, these are the conditions in which bone marrow aspirate will not give me any material. I will not get any material, known as dry tap. So how will I do the diagnosis? So for the diagnosis, I will have to take out a little bit of the bone and see what has happened. So for the diagnosis in those situations, my investigation of choice will become a bone marrow biopsy. I will have to take out the tissue. So for example, I say you had a patient who was showing you dry tap. You were not seeing a 20-year-old patient. You were doing his bone marrow and you did not get any material, dry tap. Next, you did a bone marrow biopsy and you got this picture, 22-year-old person, bone marrow aspirate, dry tap, and this picture is all fat. What is your diagnosis? You're dealing with a case of aplastic anemia. That is how you approach a case. I hope everyone's okay. Now let's come to the stains. What are the stains that we have to know when I'm dealing with the basics? Please note that in the stains, you number one have to think of what are the three things that I'm doing in hematology. You will say first, ma'am, you are taking a peripheral smear, simple ya to finger prick ya fir blood sample peripheral smear, or you are doing a bone marrow aspirate, option 2, or you're doing a bone marrow biopsy, out of which I anyway know that for bone marrow biopsy, since that is a tissue, you must be using the pink and blue of pathology, that is HNE, that is sorted. We've seen that. But what do I use for peripheral smears and for bone marrow aspirates, for the liquid blood part? What do I use? Please remember, we use a family of stains which is known as the Romanovsky family. We use something called Romanovsky family member of stain. So Romanovsky stain, we call it Romanovsky, but it's not a single. Romanovsky is something which is going to be a family of stains. So what all does it include? It includes something called, very famous, the Giemsa stain. It includes the Giemsa stain. It includes the Leishman stain. Leishman. Then we have Wright stain, Jenner stain, and also something known as the field stain. All of these, can you imagine, guys? All of these come under the Romanovsky members. That is Giemsa, Leishman, Wright, Jenner, and field. All of these come under Romanovsky. We use any one. So most of the cases we use Giemsa or Leishman, either of the two we use. And the colors you can see. So you will say, ma'am, these are the names of the stains. But what does it have? Hota kya hai? What do they contain? They contain, at the end of the day in pathology, you will come down to one blue color thing and one pink color thing. The ending of everything is the same. So if you ask me what is the composition of all of these going to be, I will again tell you there is one pink color thing which is known as eosin Y, and there is a blue color thing which you call as methylene blue or azure B. Methylene blue or azure B. So basically BB. Either you have a blue color stain, ek to blue color hota hai, which is methylene blue or azure B, and one of them is going to be the pink color one, that is going to be the eosin Y. That is what is important for you to know for the composition. Be it Giemsa, Leishman, you just keep varying. You keep, analyzing how much is of blue is more, red is, or pink is less. That variation composition will change, but ultimately there are two dyes. And can we all see this, and can we get oriented to what all cells am I seeing here? Firstly, the cells without a nucleus. What are these cells? Basic, I'm telling you. These are the red blood cells. Then the cells with a nucleus. These are the white blood cells. And finally, we have the cells over here which are very, very chota, tiny, tiny dots. These are the platelets. So repeating, we've got the red blood cells, the white blood cells, and the platelets that you have to consider. On that note, do we also need to know the pH? The pH of the Romanovsky stain that is kept is at 6.8. However, for malaria, M-A-L-A-R-I-A, how many alphabets? 7. So you have to cross the pH 7. For malaria, you have to keep a pH of 7.2. That is how I have learnt it. So everywhere in hematology, whichever of these Romanovsky family members that I'm using, I will keep a pH of 6.8. But if they say you want to do the diagnosis of Plasmodium vivax or falciparum or some kind of malaria, so malaria has 7 alphabets and I will have to cross the pH 7 for it, which is 7.2. That wraps up everything. And this basic slide I've seen so many times, students don't give any importance to this. So you have to know this Romanovsky slide. So be it a PS or an aspirate, you will use one of these family members. If it is a tissue, you will use your general pink and blue, which you always continue to using. Having